Hello everyone. Now I'll be discussing questions of diabetes. So we have a 55-year-old male and he has type 2 diabetes, hypertension is there, and he has acute MI 1 year back. Now he's taking metformin, lisinopril, atorvastatin, low dose aspirin, the standard therapy for post MI case. And his glycemic control was very good until a few months ago. But now his blood sugar are running high and BMI is 33 kg, is really very high, and physical examination is otherwise unremarkable. The lab results are as follows. BUN is in the normal range, creatinine is again in the normal range. That means there is no derangement of kidney function. Fasting blood sugar is definitely high, is 10 millimole per liter, and HbA1c is again very high. Okay, so definitely there is derangement of diabetic status is there. Now this patient has a strong desire to lose the weight by at least 11 pounds in the next 6 months. Most appropriate for reducing weight control and diabetic control. So we need a drug which has got two basic qualities that should control sugar as well as body weight. Also, the best answer of this is option B. Okay, that is GLP-1 agonist. So before I really discuss the answer that this is the correct answer, let me tell you some basic concept about the properties of various anti-diabetic drugs. Okay. So the basic concept about anti-diabetic drug in general I'm talking about. The first and the most commonly used drug in type 2 diabetes is metformin. It does reduces the HbA1c by 1 to 2%. Okay. Now about basic concept about metformin, it's an initial therapy for type 2 diabetes, especially those who are obese. The standard teaching that we talk about. If they are weight neutral or they may slightly reduce the weight, they are not a drug for weight reduction. But one thing is definitely they do not cause weight gain. So weight gain is not a feature. That's a big advantage. Okay, but it's not a drug that you can use to reduce the weight markedly also. This point should be kept in the mind. Hypoglycemia does not occur is again a big advantage of this drug, but lactic acidosis is a life-threatening complication. That's why this drug should never be given in case of chronic renal failure or chronic or liver failure. So any condition where there is already a chance of metabolic acidosis there, this drug should not be used. Now I have extra question for you. You can stop the video to write down the answer. Write down the answer in your copy. Prolonged use of metformin can lead to deficiency of which vitamin? Quickly write down the answer. The answer is vitamin B12. It means whenever we are prescribing metformin, never forget to give supplement of vitamin B12. Sulfonylurea can reduce HbA1c by 1 to 2%. Okay, and again little bit basic concept about pharmacology of sulfonylurea. They are insulin secretagogue. They are usually added in those patients who have a metformin failure is there, and weight gain and hypoglycemia. Well, it's a good drug to control blood sugar. Rather, it can even go for hypoglycemia, but they can cause weight gain, and definitely as we got in the question that we want to control blood sugar and we want to reduce the weight also. Now one more question, extra question. You can stop the video, write down the answer in your copy. Why sulfonylurea is also called as insulin secretagogue, and which other group of drugs are also known as insulin secretagogue? Quickly write down the answer in your copy. Now the first question, why sulfonylurea is also known as insulin secretagogue? The answer is, let's learn the basic mechanism of action of sulfonylurea. They act on ATP sensitive potassium channel. They act by release of preformed insulin from pancreas. That's why they are known as insulin secretagogue. They cause secretion of insulin from pancreas. They close potassium channel in beta cell membrane and cell depolarizes. So this results in insulin release via calcium influx. When the cell gets depolarized, there is entry of calcium which causes release of preformed insulin. That point should be noted very carefully. So that's why we call it to be insulin secretagogue. Point to be noted, it does not lead to formation of new insulin. Doesn't lead to formation. It simply causes the release of preformed insulin. Which other group of drug is also known as insulin secretagogue? The answer is meglitinide, which include netaglenide and repaglenide. Why they are? The reason being, they stimulate postprandial insulin release by binding to potassium channel on beta cell membrane. So they also cause the release of preformed insulin. So that's why they are known as insulin secretagogue. But of course, just like sulfonylurea, but site of action is different. But they both cause release of preformed insulin. Okay. Well, one more thing I like to add regarding these drugs. They are short-acting drug. Okay, their half-life is very short, so they are ideally used for postprandial hyperglycemia. Postprandial hyperglycemia means you got one patient who says, doctor, before meals my blood sugar is normal, but after meal my blood sugar goes high. In such cases, these are very good drugs to be used, or they are also used in those where the meals timing are not constant. Irregular timing, especially doctors, surgeons who are operating, or other people who meals timing cannot be constant because of so many constraints. So they are drugs especially used for those. And since they are short acting, so hypoglycemia is not a big problem. Well, we have another group of drug is pioglitazone can reduce HbA1c by 1 to 1.5%. Let's learn a little bit more about these glitazone. They belong to thiazolidinedione. They increase insulin sensitivity. They act on the PPAR gamma nuclear receptor. This is very, very important point from basic sciences. It is unable to used if unable to tolerate metformin or sulfonylurea. Usually not a first line treatment in type 2 diabetes. It is usually second or third line treatment. Can be used in diabetes with renal insufficiency, a distinct advantage. Okay, and low risk of hypoglycemia, one more advantage. And can be used along with metformin, one more advantage. But they can also be used for PCOS and NAFLD. Okay, polycystic ovarian syndrome and non-alcoholic fatty liver disease. There are additional uses where we can use glitazones. Side effect, they can lead to sodium and water retention. They can precipitate heart failure, so should not be used in patient having any cardiac problem. They cause weight gain. Definitely, if something is causing water retention, it's going to cause weight gain. Hepatotoxicity and bone fractures are the additional side effect that can happen with these patients. Now, I have one more question. Glitazone can precipitate which cancer? Again, stop the video, write down the answer in your copy. Well, they can precipitate bladder cancer. Okay. Then we talk about DPP-4 inhibitor. Example are sitagliptin. They can reduce by HbA1c by 0.5 to 0.8%. Well, a little bit basic concept about DPP-4 inhibitors. They again have a low risk of hypoglycemia, additional advantage. They are weight neutral. Okay, they don't cause weight gain or weight loss, and they can also be used in renal insufficiency, a distinct advantage of this drug. Now we talk about GLP-1 agonist drug, which include exenatide. They reduce HbA1c by 0.5 to 1%. Now, basic concept about these drug. Possible second agent of metformin failure, especially if weight loss is required. They are very good drug to cause weight loss. Hypoglycemia risk is low, especially if used alone or with metformin. The hypoglycemia doesn't lead to. Okay, so again distinct advantage, but they cause weight loss. Now we come to our question. Patient in our question, overweight is there, body mass index is 33 kg, and it requires HbA1c reduction also. Sulfonylurea are typically added to metformin in subnormally controlled patient. As I told you in the basic concept about sulfonylurea, but they cause weight gain and possible hypoglycemia. And we don't want weight gain, we want weight loss. So option D, sulfonylurea, is ruled out. The pioglitazone, okay, option E, they can cause weight gain. As I mentioned in the basic description also, they can lead to congestive heart failure. So weight gain we don't want to be added to this patient. GLP-1 agonist exenatide or liraglutide would be the most appropriate option B in this patient. As I told you in the basic pharmacology, they can cause weight loss, and hypoglycemia is not a risk, and they reduce HbA1c. So one ideal drug which can reduce blood sugar and can reduce body weight is GLP-1 agonist. Now, a little bit more about pharmacology of GLP-1 agonist. We all know very well that when we eat food, when the blood glucose, G for glucose level goes high, and intestinal cell, they secrete a molecule called GLP-1. Okay, this is simple basic physiology. Now this GLP-1, okay, molecule which is released from the intestinal cell, it causes glucose dependent insulin secretion. They reduce glucagon secretion. Glucagon, we know very well, increases blood sugar. So it is going to increase insulin, I for insulin. They reduce glucagon. Well, in both the way, they will lead to help in reducing blood sugar. Okay, and increase gastric emptying and so they decrease gastric emptying, and that means food will come very slowly to intestine, and they reduce appetite also. So GLP-1 agonist drugs, so the agonist drugs are exenatide, liraglutide, and dulaglutide. So they will be having all these action which I mentioned just now, and these molecules are degraded by DPP-4 and the DPP-4 inhibitor are sitagliptin, sexagliptin, and liragliptin. So they are degraded by enzyme DPP-4. So if you use inhibitor, the breakdown of GLP-1 will be less. With the longer action of GLP-1 will be there, and they inducing all these benefit. So this was the basic concept about what the mechanism of GLP-1 agonist. So now we look into option A, which is DPP-4 inhibitor. They increase endogenous incretin. Incretin is nothing but GLP-1. They improve glycemic control. They have low risk of hypoglycemia, distinct advantage. And one thing you know, that out of all the drugs which I mentioned so far, sulfonylurea have the maximum risk of hypoglycemia. Now these DPP-4 inhibitor can be used in chronic liver kidney disease, distinct advantage, and GLP-1 analogs, so-called exenatide or liraglutide, which I mentioned in the previous slide, they significantly more efficacious for reducing weight loss and improving diabetic control. Point to be noted, DPP-4 inhibitors are not that potent in reducing weight and controlling blood sugar as compared to GLP-1 agonists like exenatide and liraglutide. Now, DPP-4 inhibitor can lead to which pathology in the abdomen? Write down the answer in your copy. You can stop the video. Answer is they can lead to acute pancreatitis. This again, of course, not a very common problem, but it can induce. Option C, insulin, is incorrect. Definitely, they lead to significant weight gain and increased risk of hypoglycemia. So, second drug, of course, they say injection. In the oral group, sulfonylurea was most potent in causing hypoglycemia and weight gain. But insulin is injectable. It can lead to these two problems. Well, again, I have an extra question for you. Hypoglycemia can occur in insulin therapy and insulinoma also. Which biochemical test is done to differentiate between the two conditions? Quickly write down the answer in a copy. You can stop the video. Well, the answer is C-peptide level. But the question is, why C-peptide is the investigational choice in above case, in this case? Why C-peptide? Why not something else? Quickly write down the answer in your copy. Well, why this C-peptide is an investigational choice? Then for that we got to know the basic physiology and biochemistry of insulin synthesis and insulin secretion. Biochemistry. Insulin is synthesized in the form of pre-proinsulin and it is cleaved to proinsulin. And this, if it is stored in the secretory granules, we all know very well the basic physiology that insulin is stored in the form of granules in the beta cells. So when it is released, it is broken down into insulin and C-peptide. That means there will be equimolar insulin, I for insulin, and equimolar C-peptide. So in the normal case, in endogenous insulin secretion, both will be equal. But when we give exogenous insulin, that does not have C-peptide. So suppose there is exogenous insulin induced hypoglycemia, insulin level will be there, but C-peptide will not be there. But in insulinoma, equal amount of insulin and C-peptide will be there. That's why C-peptide is the investigation that we do to differentiate between exogenous insulin and insulinoma. So here is the proinsulin. This is C-peptide, and these we have a alpha chain and beta chain. They are united by disulfide bonds. So when we remove this C-peptide is removed, this much insulin is released. Okay, this insulin is released, and C-peptide will be there only in an endogenous insulin, not in exogenous insulin. Golden line to remember: best initial test for type 2 diabetes without contraindication is metformin. Okay, and GLP-1 agonists, exenatide and liraglutide, they induce weight loss and they have lower risk of hypoglycemia. So that's why in condition where we want to reduce the body weight as well as we want to reduce blood sugar, we prefer to give GLP-1 agonist. Thank you very much.